Thanks, Vivian. Welcome, everybody. I'm Michelle Kearney. I'm a doctoral prepared nurse practitioner, and as the clinical training lead here at Viz AI, I'm responsible for the content development and delivery of our clinical education and training. Prior to coming to Viz, I spent 20 plus years as a nurse and a nurse practitioner. For the last 12 years, I've been in neurology and stroke, and I have a practice expertise in cerebral vascular interventions. I've also been an ICU nurse, an IR nurse, a stroke coordinator, and a research coordinator. I'm really happy to be here today, so let's get started.
So we'll just be talking today about what is an ischemic stroke, why it's a big deal, and what can we do about it, and we'll focus a lot on some imaging. So let's just get started with what a stroke is. So a stroke is a sudden impairment of brain function or several parts of your brain because the blood flow to a portion of the brain has stopped, right? So this can happen either because there's a plaque or a clot that's blocked blood from getting into your brain. So here, like plaque is built up, or maybe a clot came from somewhere else, or maybe it's because there was a hemorrhage. Maybe it's because an aneurysm or an AVM or arterial venous malformation ruptured inside the brain, inside the subarachnoid space, and that caused a subarachnoid hemorrhage, or because these vessels that are inside the brain actually ruptured after years of blood pressure problems, for instance, and they actually bled into the brain, causing what we call an intracerebral or an intraparenchymal hemorrhage. But today we'll mostly be talking about ischemic strokes. Regardless, the symptoms are the same, right? You get a facial droop on one side, you get weakness on one side of the body or the other, you get numbness or tingling, slurred speech, confusion, changes in your balance or dizziness, maybe vision changes, maybe your eyes don't move in the same direction, and then perhaps headache and loss of consciousness. These are really large strokes and often are associated with those hemorrhagic types. So globally, there are already 110 million people in the world have experienced a stroke, and globally, 1 in every 4, 25% of adults over the age of 25 will have a stroke, and that's both types. And out of the 12.2 million new strokes a year, 5.5 million will actually die from a result of that. So it's still a really big problem. In the United States, there's a death about every 3.5. It's actually like 3 minutes and 17 seconds. It remains the 5th leading cause of death here. It is also our #1 cause of long-term disability. And in 2020, it cost us $34 billion. And that included our medicines, services, and missed work days. And then there's some disparities, right? So here I live in Nashville, Tennessee. So it's right here. You can see all this dark purple. Well, the darker the purple, the higher the stroke death rate. And this is something we call the stroke belt. And it's mostly down here in the South. Other populations that are high at risk are Black individuals, regardless of age, are actually 2 times higher at risk to have death from stroke, and they have the highest death rate. And then the Latino and Hispanic populations are having an increasing death rate every year from stroke. So we still have a lot of work to do. And why does that happen? Well, in stroke, it's really important to get treatments really quickly, and we lose 2 million neurons every minute. That's 14 billion synapses, and every hour you lose 3.6 years of your brain age. And the only way we can help this is to actually get people to interventions to get them to help faster. And if we do that, we get better outcomes. So if we just looked at this really overly simplistic pathway goal for ischemic stroke, you have the person has a stroke at home, EMS, hopefully they've called 911 and EMS comes to get them, they take them to the hospital. And then once somebody's in the hospital, they are worked over by this ER physician. And then if they are suspecting some sort of neuro event, they'll get some imaging, usually non-contrast CT, CTP, and a CT perfusion scan and a CTA. And then the radiologist will read this and then let the ED provider, whoever ordered it, let them know what the results were. And if it was a big stroke, then they'll tell the neurologist. And then the neurologist will then review it and then order some thrombectomy. thrombolytics, and then move on to see if they are a thrombectomy candidate. So all of this is a big phone tree. And unfortunately, we have some really tight timelines for this. So we'd really like to get a door to needle, and that means door to thrombolytic in 30 minutes. We'd like to have the artery time, a door to artery or door to access for one of these thrombectomies that we'll discuss in 60 minutes. And we'd like to have the device to get the clot out of the brain up in 90. So 30, 60, 90, and you can imagine there's a lot of conversation and communication that has to happen. So a thrombolytic it breaks down the fibrin. So a lot of these clots are kind of densely fibronic, and it'll break down the fibrin of that clot, kind of open up, hopefully, the vessel. And if we can treat them ideally within 3 hours of their onset, and we would be really golden. That's what we call it, or 2 minutes of 2 hours of when they get to us. The other thing we can do is a thrombectomy. So this happens in the interventional suite. We call it interventional radiology. Some people in a hospital I worked at called it specials. But anyway, under fluoroscopy, the interventionalist accesses a radial or a femoral artery and then inserts a catheter, which is a really long tube, into the brain vessel that has the clot in it. And here on the screen, you're seeing what we call a stent triever. You think about that like a stent on a stick, and it incorporates that clot, and you wait for about the longest 3 to 5 minutes of your life. And once it's incorporated, you pull the whole thing out. They also have something called an aspiration catheter, which works the same way. It's a larger, kind of larger tube, gets up really close to that clot, kisses it essentially, and pulls it out. So those are the two main pathway goals that we have. When I started in nursing, it was 1995, and we had nothing. I just still remember saying, sorry, I had a stroke. Here's some warfarin or Coumadin. And then in 1996, they started with thrombolytic trials, and we started with alteplase or TPA. And then after that, here, we started getting these aspiration thrombectomy devices. And at this point, I was actually working the interventional suite. And then when I became a nurse practitioner in the suite, we were actually using these stent trievers, and we saw a big difference. It really changed things a lot for these large clots that blocked big arteries. And then we didn't have a lot of studies to prove what we were doing worked. And so we did really quick studies. 5 randomized trials came out and said, yeah, absolutely, this is really beneficial. And since then, we've actually extended our time windows. And then even that, now we're using T and case again in late window treatments. And we're really trying to work on our hemorrhagic treatments. So that is how far we've come. Now, unfortunately, not everybody can do all of those new things, right? So how do we make sure that someone suffering from a stroke gets to the right place to get those treatments? Well, there are recommended, there's this 4-tier system, really. So you have this basic hospital, which we all need: assessment, identification, stabilize somebody and get them to someplace else as quickly as you can. An acute stroke ready hospital, they can give thrombolytics. They have CT scanners usually, and they often have acute stroke expertise, usually telemedicine. And then you can move on up to a primary stroke center that has a stroke unit, a coordinator, that continuum of care, so they can help people get to rehab. And then a lot of these centers were actually doing that thrombectomy, but didn't have certification for it and didn't have all of the functions of this comprehensive stroke center, which includes neurosurgery and a full spectrum of hemorrhagic stroke treatments. And they were doing thrombectomy, but they thought, well, we want to be thrombectomy capable, and that's what's happened now. So we have these thrombectomy capable stroke centers as well. So while we've come really far on that, and the newest research says that like almost 90% of us are within an hour of an acute stroke ready hospital, you can see here there's still disparity. So on the right here is the map of all the current stroke centers in the country, and on the left is that stroke death map. Well, again, I live in Nashville. I actually live kind of just center of Nashville and 5 miles within 3 comprehensive stroke centers. If I drive 45 miles in any direction, there are no comprehensive stroke centers, and it gets even worse when you get out to have no stroke centers. So that's sort of the truth. And you can see again this dark map where we have a lot of stroke centers, but we still have a high risk, stroke death rate. And even out here, sometimes you only have one center. A really good friend of mine is a physician in Alaska, and it's the only stroke center within 500 miles. So in Anchorage there. So we still have a long way to go. So we can't talk about this, of course, without talking about anatomy. So let's just dive a little deeper into the anatomy and physiology and what happens during a stroke to make all of this all these happen. So you know that each lobe and section of the brain has a specific function. So we have the frontal lobe here, responsible for smell, judgment, foresight, voluntary movement, all of that stuff. And then you move back to this motor cortex and then the sensory cortex. If you've ever seen a homunculus image, you'll know that we have a lot of brain dedicated to our arms and our hand and our fingers and our face, and even our tongue. So deep brain, lots of areas. And then if we move back onto the parietal lobe, that's where we have our attentional awareness and also spatial awareness. So these people would have trouble kind of locating something if you're trying to kind of put your hand on it, or even their own personal aspect of their own space, like where they are in space. And then what if we look at our temporal lobe, that includes all of our language and speech areas. So speech, of course, is just speaking. You can just speak clearly and it all be nonsense. And then we have our language center, which actually helps us understand language and give the language back and following commands, that sort of thing. And then we have our vision center, which is in the occipital lobe. And I say that we have, this is often called a posterior circulation stroke because these posterior strokes are often hard to find and discover. And then we have our cerebellum, which is our posture and balance and coordination. And then, of course, the brain stem here, which is our whole homeostasis and keeps us alive. So moving on to that, I'm going to turn my video on for just a second. Yeah, there it goes, to show you one, my favorite device all the time. But on the screen, you'll see that we also have vascular territories in the brain that I don't think we think about a whole lot. I think we think quite a bit about that in cardiac stuff. And we have, we know we have a lot of vessels on the heart, but there are actually a lot of vessels in the brain. And so this is a 3D model of the circle of Willis. And so, they've taught us a long time, you'll hear, oh, it looks like a spider. And I didn't see that really until I saw this in 3D. So it does look like a spider a little bit, but I'm going to put it up here. And if you're looking at me, you can see that this is what we call the middle cerebral arteries right behind your eyes. So if you're looking at someone, that's where they would be. But the carotid goes up here, internal carotid, branches off into the middle cerebral artery. And then this is our anterior circulation. So this would be my anterior circulation feeding that frontal lobe. And then there's a posterior cerebral artery that feeds the back of my brain and that occipital area with my vision. So again, internal carotid artery branches off to the middle cerebral artery, our anterior cerebral artery, and our posterior cerebral artery. Well, those deep areas in our brain that are really important for function, like your basal ganglia or your thalamus, come off of this MCA, and they have little vessels that feed it. And we often call, we'll talk about that in a minute, but small vessel disease, but they come right here. In the back, we have vertebral arteries. Name that because it comes up your C-spine and it joins into the basilar artery, which then feeds your brainstem. And you can kind of see the hole there that you can see where your brainstem would fit right in. And then these, of course, are these cerebellar arteries. And so looking at that, imagine that if you have, and I'm just going to change the slide here so you can see what's really interesting about this is how much territory here that the MCA takes care of. So on the screen here, it's your orange part. If you just took your thumb and you branched it off from your middle cerebral artery, you can see that this would be that much territory. So if you have a stroke in this MCA, which is where a lot of our thrombectomy started, it would be a really large stroke. So here's another example of that. If you'll look at this, you can see that the carotid comes up, it branches off to this MCA, and it's all of this territory here. So just to recap all of that, if you have a stroke in your left carotid artery, you're going to block off all the blood flow to all of this brain, right? So all of these functions are going to be damaged. That's going to look like a pretty large stroke. If you block off this middle cerebral artery, you're going to block off all of this territory. So that was your language area. It's going to be your spatial awareness. It's going to be your basal ganglia. It's going to be another large stroke. And if you block off here, your anterior cerebral artery, it's going to hurt you. It's going to get that frontal lobe, some of your motor and sensory cortex. A lot of these times these patients have strokes, but you'll say, oh my gosh, they don't have any function problem except maybe a motor or sensory deficit. And then here is that posterior circulation stroke, and that's going to stop all the blood flow back to the posterior area, which again was vision. And then finally, if we block off our basilar artery, we're going to have somebody who's comatose and has had a really large stroke because we're blocking off the brainstem. And then the cerebellar arteries, if they were blocked off, you're going to have that dizziness. So from all of that, we get this Be FAST acronym. So for a long time, we just said FAST, which was face, uneven, arm weak, speech is slurred, you're having trouble getting your words out. And then it was time to call 911. So because we were missing a lot of the balance, somebody comes in and they're dizzy and you don't think they've had a stroke, you think they've had vertigo, but we were missing those cerebellar strokes. And then we were also missing those posterior circulation strokes with the vision loss, or even some kind of, sometimes they have really strange nystagmus. And that is, we were missing those. So we changed our acronym, or kind of updated it to say Be FAST. So balance, eyes, face, arm, speech, and time. And I would say here that I told you earlier that the hemorrhagic strokes have really terrible headaches. And so I like to think of T as terrible headache as well. So what causes these? In addition to these that are listed here, there are others. But in 1993, they had something called the TOAST criteria. And while we've kind of, we've revamped it some here and there, it's actually still one of the things that we use quite a bit, especially when talking to patients or doing education. But you have kind of 5 different types. So we have these large vessel disease. If you think about that, that's going to be your carotid. That's going to be like atherosclerosis, really thick plaques. People have hyperlipidemia. These can also happen when somebody is dissecting an artery because it causes a flap and then a clot forms on that flap. And then we have small vessel disease, and that's usually hypertensive people, diabetes, tobacco use, and again, hyperlipidemia. Then we have the cardioembolic, and this could be cardioembolic or just embolic too. That usually comes from some sort of cardiac arrhythmia. Atrial fibrillation is the main one. Maybe you have a big clot in your aorta. On the curve there, maybe there's a vegetation on a valve. And then 5% of that we know, and they're rare, but I've had a couple of patients come in and find out they've had cancer. They have cancer because they have had a stroke. This 30% here, believe it or not, 30% of the time, we're just not quite sure why somebody had a stroke. And so then we have to do further investigations. But a lot of times it's AFib we can't see, or maybe some other hypercoagulable problem we don't know about. So just a little quick graphic about that. So you see here would be the aortic arch atheroma, and it's over here on the clot. It's branching off here on the aorta. And then you also have AFib. So AFib is when you have AFib, you're really high risk to have a stroke. And that's because the atrium that we know, we've always thought the heart has 4 chambers, but they actually have these appendages off the top. So the atria have appendages, and to me, they look like little chicken wings off, but when you have AFib, the atria are kind of not together, and the blood starts to clot in these appendages. And then over time, those clots will just fly out and go straight up into the brain. And they often are full of fibrin because they've been there for a while. And so here's kind of a diagram of what happens. This fibrin clot gets blocked here. And now you'll see that this is the MCA and it's blocked off. So part of the brain is dying. So this is pretty ischemic tissue. This part is still also, if we don't do anything, it's certainly going to die. But because we have that circle of Willis, this is the ACA coming up here, this is the PCA, we're getting some good collateral blood flow. So collaterals are really important to how much time we have to save somebody. So we have some blood flow and gives us some time. The other thing here is this would be a large vessel disease, right? This carotid's kind of plaqued off. And then when we say small vessel disease, I feel like that's a misnomer. It makes it sound like somebody should be just fine. It was just small vessel. But this is where your basal ganglia is, then your thalamus. And if you think about that area as your air traffic control, the way you stay awake, how about you get a signal from your body to your brain? All of those crossovers happen right here. So you can imagine when these are blocked off, you have really large strokes. We just happen to call them small vessel because they're small vessels. And so who are these in practice? Who are these patients in practice? So Alice, if you just think about this, is a 63-year-old lady. She fell 3 days ago, and now she's 2 hours post hip replacement surgery. So in the recovery room, she's awake, but she's slow to awake. She's babbling her speech and she's not following commands. So her blood pressure is 142/85. Her heart rate is irregular, and we did an ECG and we found out she's an AFib at 110. And her vital signs, otherwise, her stats are okay, and her respirations are 22. Her catheter, she has one of those in, and it's 40 cc's of dark urine over the last hour. So I think a lot of us are like, oh, well, I don't need to know about neuro because I'm not on a neuro floor. But you can see that, Alice here is probably on ortho or a med surg floor or anywhere else in the hospital because there weren't rooms. And so everybody, it's really important to do an assessment. So it's hard to know what to do on a neuro assessment. I know we all have, I was a stroke coordinator, so a stroke NP. We had to really come up with kind of a standardized neurological assessment for everyone to use. And so the AANN a couple of years ago, we came out with this white paper standardizing that neurological assessment. And it's really just 5 pieces. First, we want to know what time. So we'd like to know how she was, right? When was the last time she was in the last known normal for her? What time the surgery start and stop? What's her level of consciousness? Well, she's waking up slowly. She's not quite alert. What about her language and speech? Well, she's not following commands and she's babbling, right? And then if you do your cranial nerves, which if you're like me, didn't memorize that acronym at all, and this is terrifying, but it's not so hard, right? We're just looking at somebody's face. Is it even? What about their tongue? Is she moving her tongue? Is she able to tolerate her secretions? Is she coughing? Is she drooling? What about shrugging her shoulders? Is that working for her? What about her eyes? Are they following people around the room at least, making eye contact? And you've done your cranial nerve assessment, your movement and sensation. And here we want to know if she's moving and if she's moving symmetrically. And if you can't get her to tell you if she's got sensation, you can always do a little stimulus to make that happen. And then again, our sixth part of this really is the vital signs. So I've told you that she's got AFib, her heart rate's 110, her respirations are okay, and she's still satting. So what about this? Like, is she a neuro patient? Hard to say, right? She could be having a stroke, right? But she could not be. So there's several things. She might just be hypoglycemic. Maybe she's hyperglycemic. Maybe she fell and no one told you and she actually had a little head trauma. Maybe she had an old stroke. And if you're familiar with strokes at all, if somebody had an old one, once you give them an illness, you wouldn't give them an illness, but once they have an illness, or maybe they're after coming out of anesthesia, those stroke symptoms sort of show up. And so recrudescence of that. And then maybe she has, she's just not waking up for anesthesia. So she has a drug or alcohol effect here. Or maybe she had a seizure while she was under. So it doesn't have to be a stroke, but it certainly can be. And time is of the essence. So knowing somebody's assessment before that really makes a difference. And so what about a TIA? Is a stroke, is a TIA a stroke? I get this question a lot. And what's good to know about this is 1/3 of the patients who have a TIA will have a stroke in 5 years. That's what we do know. I like to think about this as a stroke that didn't leave a mark. So you do an MRI on these people and they've come back to their baseline and there's no stroke on the MRI. So my grandmother would have called this a mini stroke, but we would call this now a trans-ischemic attack. The problem is this is kind of a warning sign, right? So we need to still figure out why they are having this issue. Overall, the same causes, right? Hyperlipidemia. Sometimes people look like they have a really large stroke, and that's because there's a plaque on their carotid that's kind of broken off, and then it'll block back up again. And so those people might have to have an immediate surgical treatment. But most people, when they have these, we certainly don't do thrombectomies and we certainly don't do thrombolytics. But our whole goal is to prevent a stroke. So Victor here is going to help us through the rest of the presentation, and he's 67. He has a history of hypertension, diabetes, and he came to the ED after an acute onset of slurred speech. He has left facial droop and left-sided weakness, and he was out riding his lawnmower. So his symptoms started about 3 hours ago per his family, who found him in the yard. So on exam, it gets to you, he's got severe dysarthria, so he's got slurred speech. His whole left face is the bottom of his left face. He's got left-sided arm and leg weakness. And he has left hemisensory loss and some neglect. So he's not really noticing his left leg. It's called, we call that neglect or nausea, where it's an interesting phenomenon that happens with patients who have strokes on this side, and that they don't really recognize their own body part or even like a side of a plate if you're looking at your dinner plate. So let's ask some questions. So as Vivian mentioned, we'll do a little interactive sessions here. So for a knowledge check here, which side of the brain has been affected to Victor, and which vascular territory is most likely affected? If you think back to the model that we talked about earlier, and which territory is fed which part. Yeah, everybody's doing really great here. So yeah, he's got all of these symptoms on the left side. And so this is going to be a right middle cerebral artery stroke, right? Because he's got dysarthria, he's got this facial droop, he's got left arm and weakness. So he's got a pretty large stroke, which is probably meaning that his MCA territory is affected here. And then next, what about his facility? Which facility type do you think Victor should go to? Should he go to a comprehensive stroke center, a thrombectomy certified center, a primary stroke center, or an acute stroke ready hospital, or maybe the closest? This is always my favorite question because it's so sneaky. So I appreciate everybody. And as usual, everybody's got this right. And there are two answers, really, right? The CSC would be awesome for him. Like he's having a pretty large stroke. And but if he's not near one, if he's not here in Nashville and you're next to 3 comprehensive stroke centers, you're going to have to go to the closest. And now every city, every state, every county seems to have a different protocol for this, but these are based on state protocols and EMS protocols. So they come and they evaluate the patient. And if they think it's a large vessel stroke or really something big, then they certainly want to take them to a comprehensive stroke center. But you're not always close to one of those. And so the American Stroke Association, their guidelines, you do that and you go to the closest, right? If you're not within 30 minutes. All right, good job. So next we've talked about his assessment, right? But when somebody comes to you and they have a stroke, you actually have a few scales that we have to do, right? So first, we have this NIH stroke scale. So if you know about that, we're testing your level of consciousness, how well your eyes move, your vision, your face, motor movement, sensation, speech, and language, and then whether or not they have that neglect that Victor seems to have. And then the stroke scale is like most things in stroke and neuro, the higher your score, the worse off you are. It's not when you want. This is not the time to get the best score in the house. So 0 is no stroke symptoms, and then a severe stroke would be 21 to 42, and then moderate to severe would be 16 to 20, and then moderate is 5 to 15. So these are the patients that we really worry about. These minor stroke patients, if sometimes we're like, oh, well, then we don't need to do anything, but you could get just a language problem and say, for me, if I can no longer speak, that is a really big stroke for me, and I would like to have treatments. But we use these scales to help us know if we should give folks treatments. And you can imagine that we also like to know what somebody is like when they get here. So this is always when we say we want to know what your modified Rankin scale is, that means before you see them. So not Victor right now, but Victor out on his riding lawnmower. And that's how symptomatic was this person before? Are they no symptoms? Did they just walk with a cane? Or were they bedbound? Things like that. So those are the things we like to know because we like to treat people that we can actually make better. So if somebody's already bedbound, is anything we're going to do going to change that? So just keep that in mind. The other thing to keep in mind is the worse off, again, your NIH scale, the poorer your outcome is going to be. And to that point, what do you think? So Victor's NIH is a 12 on exam. So it's a moderate stroke for him. What do you think his modified Rankin scale is? Is it 0, 1, 2, 3, 4, or 5? Don't include 6 because we know that is, he's alive. So it's not that one. And just remember again that this is Victor before you see him. And this is a hard one, I think, really. So you don't know, right? You got to ask some questions, but you have to make some assumptions. So if his family comes in and they're like, oh my gosh, yeah, my dad is fine. We were just at church this morning. We did this and we did this. He walks by himself. He drives himself. He still has a job. But we don't know a lot, right? We know that he was out riding his lawnmower. So we're going to assume that this guy was pretty normal. So we would have to make kind of an assumption that he was zero. So those are some of the sort of things that you would ask. What's his normal daily function? Can you leave this guy alone? That sort of thing. So his MRS is, we're going to say 0. And then next, what about who out of here? Who do you think has a better chance of being back to normal in 30 days, knowing what you know about the NIH? Is it this 48-year-old guy who had an MCA stroke affecting the left side of his brain with an NIH of 17, or a 70-year-old woman with an MCA stroke affecting the left side of her brain with an NIH of 5? So yeah, everybody got this 100%. Yeah, it's a 70-year-old woman with an MCA stroke affecting the left side of her brain is probably going to do better than my dogs. Sorry about that. Because the NIH is 5 and his NIH is actually 17. So if we don't get him treated, he's certainly not going to do very well. So let's talk about that. Let's talk about treatments and how we decide based on not just those scales, but maybe some imaging, right? So our whole goal is saving this penumbra. So what we want to do, we call penumbra, is this at-risk tissue. So as soon as you have a stroke, there's always going to be a part of the brain that's just dead, right? It's called the core. Then there's a penumbra or ischemic penumbra that's ischemic, but not quite dead yet. So if we leave it alone and do nothing, it will eventually, over time, become also dead core tissue. So the whole goal really is to save this area that's still at risk, being fed by those collateral arteries. So how do we know? Well, stroke was really also an imaging algorithm in my head. So if the patient comes in, I showed you the really more complicated algorithm when somebody comes in, but if you just say, is this a stroke? Maybe we'll do some assessments. We'll do our NIH or modified Rankin. We'll do a non-contrast head CT. Why? Because it helps us know if there's a bleed and if we can give thrombolytics. Now we're going to do a CTA. Why? To look for the vessels. We talked about those vessels. Is there a big vessel blocking the brain there? Is there a clot blocking one of the big vessels? And then we're going to do a CT perfusion to find out how well the brain is actually doing in this setting. How's that collateral flow going? How bad are we doing? And then whether or not we can do a thrombectomy. So it's really an imaging algorithm. So we start with that non-contrast head CT for 3 reasons, really. There are 3 things that are going to be white on a CT scan. One is blood, one is bone, and one is contrast. So I've told you that when we do strokes, we do non-contrast head CT. So there's no contrast. So what we're going to look at here is bone or blood. If it's white, it's either bone, and here you see the skull, or maybe sometimes you'll see a little calcification, or it's blood, and you see that this is a really large hemorrhage. This is something we call a hyperdense MCA sign. So the vessel's actually clotted off, and the blood is just sitting there, and you've gotten the scan at such a time that you can actually see it. And then if you wait 6 hours on this same patient and you do nothing, you can actually start to see some changes in the brain. So that's the other thing the non-contrast head CT will tell us, is whether or not there's already damage. So you can see probably about 6 hours, you start to see some differences. And when we're looking at this CT scan, know that this is your right side. So this would be like you looking at someone. This is the right side of their brain. This is the left side. So we have this little MCA sign here. And when you compare them, well, this no longer looks like this, right? So this looks weird. Definitely losing some differentiation between your gray and white matter. And then if we leave it, it's just going to go essentially hypo or isodense. Going to be able to tell the difference anymore. And so hypodense here is this right here. Once it becomes a chronic completed infarct, it's just black, just like your ventricles here on the screen. So this is brain that's just really no longer there. So we also want to know if we can give somebody a thrombolytic. That's why the other reason we give do that non-contrast head CT. So within 3 to 4.5 hours, we can give something called alteplase, which is TPA, or tenecteplase or T in case. So they're both given within 3 to 4.5 hours. If the onset's not clear, then they're actually saying, there are a bunch of studies out there that say if we do an MRI or maybe CT perfusions, there's extendi, some studies out there saying that you can actually give these in late windows given certain parameters on these other tests that we're going to talk about. But for right now, non-contrast head CT within 3 to 4.5 hours and a few other issues, but it should help break up that clot. The difference in these now is that this is TPA. It's delivered in 1-minute bolus followed by a 1-hour infusion. Tenecteplase, T in case has been around a long time, but it used to cause a lot of bleeding. So they brought it back at a lower dose recently, and you can give that delivered in 5-second push one time. So all of the centers near me are now on T in case, mostly for logistics. No more 2 IVs. You don't have to wait, etc. It's just a one-time push. So those are our thrombolytics. Now, if you were looking at this CT scan, what do you think it is? Is this an acute MCA territory infarct? Is it a subdural hematoma, which is a bleed? Is it a chronic MCA territory infarct or intraparenchymal hemorrhage? Yeah. So what we do know is that, like, if it becomes a chronic stroke, infarct, then it's going to really just be black. And so this is right. Everybody got this right. An MCA, it's chronic. An MCA territory infarct, just chronic. If it were acute, it would maybe not look like anything. And with that said, what do you think about Victor here? This is his CT scan. Is he having a stroke? What do you think? Yes, no, you're not really sure. So if you've ever been in a CT scanner or been around us when we look at this, it can be really annoying if you're not used to stroke, because we say, oh, good, the CT is negative. And then you're like, oh, so this guy who looks like he's having a stroke is not having a stroke? And no, he's having a stroke because he's got all of those symptoms we talked about earlier, right? The good news here for Victor is it's a negative CT scan. When you're looking at him again, right side, and we said he was having a right brain stroke, right? So his right brain looks pretty good compared to his left brain. We don't see a lot of early damage. We don't see any blood. So he's having his CT is negative, which is great, right? He's having a stroke. Looks like we've still got some time. We don't have any damage. So that's what we mean when we see the CT is negative. So yeah, he's still having a stroke based on his symptoms, and we didn't find anything on the CT. So good for him. And now let's just talk about those vessels, right? I showed you the model earlier. And so just look at those a little bit. So we look at those in imaging with a CTA or a CT angiography. And we do this by using IV contrast. And it's timed for contrast to highlight all these cerebral arteries in a single phase CT. And it's pretty widely available, and it helps identify any arterial occlusions, where the clot might be. Maybe there's something else going on. If we're having a hemorrhagic stroke, you can often see the aneurysm or maybe one of those AV malformations or arteriovenous malformations. And it can help us remember we were really interested in that collateral flow. So you can see here, unfortunately, for Victor, he's definitely having a stroke and he's got a large vessel occlusion. So his MCA on this right side is blocked off. And so we can look at that and see, well, he's still got a little bit of collateral. We see his anterior cerebral artery feeding this area of his brain. He's got a little posterior circulation still too. So we've got a little time for Victor, but we knew that on our CT scan. But what do we do now, right? So in 2019, they kind of updated some of our thrombectomy guidelines because, we like to give this therapy to people as fast as we can. And for a little bit, we were saying, you know what, you don't need TPA. You should just go straight to the suite. So they said, no, you should still give TPA. And then if somebody has all of these perfect symptoms, like they have that, they're perfectly healthy before they got to you. It's the ICA, the MCA is occluded. They're over 18. They have an NIH of more than 6, and they have not a lot of damage on their scan. Then you don't really need to do a whole lot of things. You just need to take them, right? You don't have to do a CT perfusion. But what we do know is now, hey, we can actually treat these people not just in that front M1, but we can do it farther out. And we can do these up to 24, maybe wake up strokes. We can do a lot of stuff. But what we need to know is what the mismatch is. And what does that mean? Well, that basically is saying how much of the brain is dead already and how much is not. So we'll look at that with our CT perfusion. So that comes to our penumbra, which I guess in Latin means the space between darkness and light. So I say that this is space between core and ischemic tissue. So again, I told you, once you have a stroke, part of its core, it's dead. It's nothing you can do. So we do a CT perfusion because it evaluates the blood flow in the brain parenchyma, and it helps locate an occluded vessel. So it's, basically historically cheaper than MRI and more widely available. So we give contrast, and then it just kind of over a few, it just keeps taking a picture of the same vessel over and over, the same area over and over again in a short period of time. And then we make all of these really great maps. But what it helps us do is it'll show us when there's things that aren't just quite right. It helps estimate the tissue at risk, which is that ischemic penumbra, and actually helps understand where our maybe our infarcts would be. So you can see here when you're looking at this is left side, this is right. So the right side looks okay, but this is all dark blue, right? That doesn't seem quite right. So this is the blood volume inside the brain in this area, and this is the blood flow. So the darker it is, darker blue, it's not flowing so well to this area. So now you're, concerned. And then here, it's taking a long time for the blood to come through. So you can see on these CT perfusion, you get these different maps to look at, and they look different based on the blood flow going through. And just a quick review about what our cerebral perfusion pressure was. If you remember, we know that that's systolic blood pressure minus 2 over times our diastolic blood pressure divided by 3 minus our ICP, right? Okay, that's a lot. But we know that we need to keep somebody's cerebral perfusion pressure above 60, right? That's normal perfusion. Once we go under 60, a lot of bad things can happen to someone. So the same thing for this just area of brain. So once we get below 60, so if this perfusion drops below 60, we're going to start to see some blood flow problems. And if it drops less than 30, that's kind of our cutoff, then we know that that is probably core. And within that ischemic area, some of it's still going to be okay, but we need to get to somebody as fast as possible. So again, you can see that this looks different. So we're really looking for those with small cores and large at-risk areas. So that cerebral blood flow of less than 30, remember that number is most sensitive. And then our ischemic penumbra, what we can say is at risk is the flow. Let me just show you that in a waveform, which if you don't worry, it's not bad. So these are CT perfusion curves. So that helps the contrast goes in, and it gets imaged, like I said, over and over in the same area, and as it goes out, right? So it keeps getting imaged. So what it tells us is, one, how much volume of blood is in a volume of brain over time. So if there's not a lot over time, if this cerebral blood flow, that's not good. We're going to call that core, because you don't need blood in an area that's not working, if you think about it that way, or it's not going to that area. You got a lot of core infarct. Then how long does that take? So if the contrast goes in a normal brain, you should get this waveform in like 3 seconds. If it's over 6 seconds, then it's your brain is just having that tissue is actually taking a second to get that blood flow through. So basically, you're not going to have really great uptick if your brain's not doing really great, right? So that means this Tmax. So it's taking a long time, and that's what all that red is. So this is all at 3 seconds. And then once we get to 10 seconds, it's red, and 6 seconds, it would be yellow, etc. But this is it's all about a waveform. And so now let's just look at that in Victor to make this a little clearer. So guidelines, actually, the American Stroke Association said if that ischemic core is less than 70, you should treat it. If the mismatch is more than 1.8, then you should do it. And if you have a volume of more than, the mismatch is more than 15. Don't memorize these numbers, because we're not in the habit of just saying we treat people by numbers. We've been told that our whole careers, right, as nurses. We don't treat the numbers, right? So let's look at that. So our relative cerebral blood flow, and that's the volume of blood and the volume brain and how much is flowing, right, over time, is 54 cc's on him. So you can see that this is all red. This is what it's suspecting to be on the CTP dead brain. So then the next thing we want to know is how slow or how fast are things going? So we have a Tmax of greater than 6 seconds. If it's greater than 6, then it's at risk. So that's going to be our ischemic penumbra, and that's 91 cc's. Now, this 91 cc's is going to include some of this core. That makes sense. You can see it on the map, right? So our mismatch volume is going to be this 91 area minus what we think the core is. So that's going to be 91 minus 54, and you're going to get a volume of 37 cc's to be our mismatch. And even by the rules, that works for us because it's more than 15. And then our ratio is just going to be this 91 divided by the core. So that's 1.7. We're off there. Again, it's fine, right? So what do you think? Is Victor a mechanical thrombectomy candidate? We've looked at his non-contrast head CT. We've looked at his CTA. We know he's large vessel occlusion. And then this is what his CT perfusion looks like. Yeah, so we're going to take him on because we know, even though it says he's got this large core, we didn't see it on our non-contrast head CT, if you think about that. Plus, we know that people do really well given a thrombectomy, and we don't want to keep him from having it just because he's got a 1.7 instead of a 1.8. So we're going to go ahead and take him on to the suite. There are some limitations to CT perfusion. If somebody's moving around a lot, which can happen, if somebody has a lot of implants, now that doesn't usually include a dental implant, or maybe they have really bad vessel occlusions inside their brain at all time, you can imagine that's going to change that flow because we're using that graph and how fast does that blood flow through there, that contrast does. If you've got a lot of tight vessels, it can really change that waveform. And then again, for the same reason, somebody with poor cardiac output because of AFib or a big MI, maybe IV is really tiny, or maybe the contrast was mistimed, or the injection rate slow. All of those things could cause problems for you. So just quickly to knowledge check that, which of these could limit the usefulness of the CTP? If somebody is moving around a lot, patient with heart failure and a low cardiac output, somebody with a small IV catheter gauge, or a person with a metal implant in their head. You can check all that apply. Yeah, it's all of these. Everybody's like, yeah. It's all of those. Absolutely. All of these things that happen to us when we're in the scanner with somebody for sure. All right. So why not do an MRI, right? You see MRIs a lot. They seem to have a lot more information, and it's actually considered the gold standard for perfusion. The problem, of course, is that it takes a little bit more time, and it can be hard to monitor people and it could be hard to monitor somebody when they're in the MRI scan, right? The MRI, however, is still better at detecting small lesions. Its perfusion won't be just in that one spot. We had a contrast shortage during COVID that wasn't applicable to see MRIs. And we are using MRIs for those late decisions, like those new decisions for those late window treatments. It can also help us, hey, this is not a stroke, it's a mimic. The problem is that the CT scans are fast. They rule out bleeds really quickly for us. It's easier to monitor your patient. The staffing is better. It's more available. And to be honest, as a provider, just feel a lot more comfortable reading these CT scans and based on all these pivotal stroke studies, right? So that's part of the reasons that we use CT over MRI. But if you want to know if it was a stroke on an MRI works on diffusion weighted imaging. So it's the random motion of water, right? So these are the two scans we look at the most. If it's not doing well, so if that random water of motion or that diffusion weighted imaging, it can be damaged, right, for a stroke. And so if it is abnormal or restricted, it will be bright. And then what we have is kind of a measurement of how restricted that is, and that is the apparent diffusion coefficient. So how abnormal is it? So when that is abnormal, it's dark. So if you have something that's bright on DWI, so we've got an abnormal restricted area and it's really dark over there, then it's a stroke. If it's bright on both, Well, it's probably artifact for some reason, but we would still kind of investigate that DWI. So just go over some quick treatments. It's hard sometimes because we certainly want to do interventions when there's a penumbra, something to save. If there's a whole lot of core, there's just not something we really treat or something we can treat. It's like watering a dead plant. If you try to reperfuse a brain that's got all of that core, when you watered that plant, if the soil's so dry it can't take in the water and it just falls everywhere. So that's sort of what happens in a stroke. They start to bleed. And then we certainly don't want to do it for somebody who's not having any symptoms. They might look like, we're not treating numbers if somebody's doing just fine. So again, back to our acute pathway, we're really wanting to know if we can give thrombolytics and whether or not we need to do a thrombectomy. So we're going to take Victor onto the thrombectomy. And I showed you earlier, this is what a stent retriever is. It's a stent on a stick. And again, you have this tube up there, incorporates the clot in that stent. You wait 3 to 5 minutes and pull it out. Aspiration's got kind of a larger bore catheter, kisses that clot, usually has this some sort of suction canister with it, and you aspirate it out. But these are the sorts of clots that you see coming out of there. And when you're in the IR suite, they use fluoroscopy in contrast. And so here is Victor pre-thrombectomy. So this is looking at Victor. So this would be his left brain, and this is his right. You're just going up the right carotid with contrast. You could see there's seems like there should be more vessels, right? So this is his anterior cerebral artery, and this is his MCA, and it should have a lot more vessels out here. So after we pull that clot out, you can see, sure enough, we've got blood flow again, and we give those Tiki scores. And the higher, the better. And so here's the side or sagittal view. So if you're looking at Victor, remember I did my thumb on my head there, and now we're missing some vessels, right? I told you that MCA takes up a big territory. Well, there's not a lot of stuff being fed here, but we've got the clot out, and now you can see there's a lot of reperfusion all the way up into here for him. So good news for Victor. And then the next day we did an MRI to see if our CTP was right? So we had that core area, and we had our we had our ischemic penumbra that we were trying to save. And when we look at his MRI, sure enough, he ends up that DWI is abnormally restricted. So he had a stroke in this whole area, but you can see that it still kind of told us that we're going to have a really large core, and we kind of have more penumbra than that. So good news for Victor, right? He does have a stroke, but it's not as big as this, because if we had left him alone, this is how big his stroke would have been. So after all of that acute stuff, we actually try to figure out, what happened to Victor? What made him have this big clot in his artery? And so if it was high blood pressure, we're going to try to fix that, make sure if he's taking his blood pressure medicine. We're going to try to get some social work if he can't get his medicines. And then almost everybody gets an antiplatelet, which is aspirin or Plavix. Maybe he had a big blockage in his carotid. Maybe he needs a vascular consult. If he's been smoking, we need to stop that. And if he has hyperlipidemia or diabetes, we need to get those under control. And maybe we didn't find out. Maybe he's got AFib and we're not sure, or we found it. And if we didn't find it, we might need to send him out on some sort of monitor. And then an echocardiogram can also help us there. And if he had some sort of hypercoagulable state, then we would need to get some sort of consult. So let's talk quickly about workflow and AI. So before AI, we went through this. The patient comes in, we did a scan, the radiologist read it, they call the ED provider called the neurologist reviewed it, did some stuff called a neurointerventionalist. The neurointerventionalist had to call in the team, and then they did the procedure. So that's a lot of phone calls, and we still had those tight windows. Well, if we don't get to somebody really quickly, then it causes issues. So this is one of my patients at an outside facility. So a primary stroke center, the patient had a inpatient stroke. And then the initial CT had no damage, but there was a large vessel occlusion. So he needed alteplase and a transfer to us. And that's what happened. So, he had alteplase. So that was good. Good news there. He got alteplase right away. Unfortunately, They also found that his arm went blue and he had no blood flow to it. So they elected to get that clot out. Well, while that's happening, he still has that large vessel occlusion in his head, and he started having respiratory distress and had to be intubated, and we had to change the ambulance that was coming. And all this is happening. Of course, we don't know about it at our comprehensive stroke center. And then the LVO was still there when they got him shipped to us. But unfortunately, now he had a lot of that isodense area. So when we looked at his non-contrast CT, there's no more salvageable brain for him. And he actually didn't do well. So we didn't do so great getting his artery time or device time right in that instance because we didn't transfer them. But a lot of that has to do with communication. So what the changes that AI do is that you've got this, the patient still comes in like always, they get those scans, then immediately the scans are available on your mobile device or immediately to everyone. So not only does the radiologist have them, so does the ED provider, so does the neurologist, and so does the neurointerventionalist. So you get these alerts. So everybody knows really quickly, and you can do thrombolytics and you can do thrombectomy candidate decisions quickly. And if you need to call on the team, you certainly can. What we do know is that AI helps have better scan review times, better door to needle times, better door to artery and device times, better door to revascularization times. And if you're in one of those transfer centers and that comprehensive stroke center knows about it, you can get somebody out a lot quicker. So much so that they recommended that all stroke centers have AI in their workflow now. So one, in summary, some key points. Thank you so much for your participation today. It makes it a lot more fun, and I really appreciate it. Ischemic stroke still is a major health concern. We have to be aware. We have to be eager to communicate, right? Somebody's having a problem, and our acute management always is about preventing any worsening ischemia, and our interventions are based on guidelines, and those are evolving really quickly because of imaging techniques. And then after somebody's had the acute stroke, then we really need to figure out, hey, what happened? What caused it? And let's prevent that from happening again. And AI is proven to decrease time to treatment. So with that, if you have any questions, and you can put them in the chat or even in the Q&A, but you can also, if you think about them later, email us at education.training@viz.com. We do have other courses, including a couple of really in-depth courses on CTP, which are terrific. We have one on hemorrhagic stroke and subdural hematomas. But when you do your survey, and Vivian will talk about that in just a second, any feedback we really read it and change some of our courses. So if there's something you'd like to see, let us know.